Ever had that feeling, when you cough really hard and maybe pull a muscle? I imagine something like that, but way, way more serious. Today, we're doing a deep dive into Boerhaave syndrome. It's rare, thankfully, but it's an incredibly critical condition. We're talking about the esophagus, the food pipe, suddenly tearing open. It's genuinely life-threatening, so understanding it quickly is, well, vital.
It really is Boerhaave syndrome, yeah. Or spontaneous esophageal rupture, as it's also known. It's essentially a full-thickness tear right through the wall of the esophagus, and the spontaneous part means it usually happens because of a sudden, really intense spike in pressure inside the esophagus itself. We're going to be using your revision notes today to really pin down the key facts you need for this.
Okay, so spontaneous, meaning not from like an external injury. It's all about this internal pressure buildup. What actually causes that pressure to spike so dramatically?
The most common thing is forceful vomiting or retching. You get this huge, rapid increase in pressure inside the esophagus, especially if the muscle at the top, the upper esophageal sphincter, stays clamped shut, sort of like trying to force air into a balloon that's already tied off.
Right, that's a good analogy. And you mentioned full thickness and transluminal earlier. Why are those terms important here?
Full thickness is key because it means the tear isn't just superficial, it goes through all the layers, creates a hole, basically. Transluminal just sort of emphasizes that connection from the inside, the lumen, straight through to the outside. And the major consequence, the really dangerous part, is that this lets stomach contents, acid and food, leak out.
Leak out directly into the chest cavity.
Oh, okay.
That's bad. That's the core danger, isn't it?
Absolutely. Those gastric contents spill into the mediastinum, that central compartment in the chest holding the heart, major vessels, the esophagus itself, and potentially even into the pleural cavity around the lungs. This contamination triggers a really severe, fast-moving inflammation.
Wow. So the body's internal environment is suddenly dealing with stomach acid. Not good. Now, vomiting and retching are the main culprits, you said. Are there other ways this pressure can spike, or other factors involved?
Yeah, while that forceful vomiting is number one, anything that significantly ramps up pressure inside the esophagus could potentially trigger it, especially if there's maybe an underlying weakness in the esophageal wall already. Things like severe overeating, maybe heavy alcohol consumption, or even getting a large piece of food stuck.
Okay, so intense strain on the system.
Yeah.
And you mentioned underlying weaknesses, like specific conditions.
Yes, exactly. Certain conditions can affect the esophagus's structure, making it more vulnerable. Things like Oesophagealdiverticula, little pouches that can form, they create weak spots. Or conditions like esophageal cancer could also weaken the wall, increasing the risk of rupture under pressure.
Right, so it's often that combination of sudden force hitting a weak spot. Who tends to be more at risk for this sort of perfect storm? Are there clear risk factors?
Definitely. Heavy alcohol consumption is a significant one, particularly when it's combined with binge eating and then subsequent vomiting. That whole cycle, the repeated forceful retching, plus maybe alcohol weakening the lining itself, it really ups the risk.
That paints a very clear, high-risk picture. What about eating disorders? Does that play a role?
Yes, things like bulimia nervosa, where self-induced vomiting is frequent. That repeated stress and pressure on the esophagus time after time can definitely weaken it, makes a tear much more likely eventually.
And it's not just current habits, is it? Does someone's past medical history matter?
It can, absolutely. If someone's had previous esophageal surgery, for example, or maybe radiation therapy to the chest area, these things can sometimes compromise the wall's strength, its resilience, making it more vulnerable to tearing, even with maybe less extreme pressure changes.
Okay, that makes sense. So we have the pressure, the potential weak spots. Can you walk us through what actually happens physiologically when the tear occurs?
Sure. So it usually starts with that sudden, intense pressure spike, the vomiting or retching. This pressure finds the path of least resistance, the weakest point in the esophageal wall. And like we touched on, that tear most often happens down low in the distal esophagus, near the junction with the stomach. That area just tends to have a thinner muscle layer naturally.
So the weakest link gives way.
Yeah.
And once that full thickness tear happens, what's the immediate fallout?
Right. So the tear occurs and immediately stomach contents, acid, enzymes, partially digested food leak out. They pour into the mediastinum. Now, this space is normally sterile, right? So introducing these highly irritant substances kicks off a massive inflammatory response that's mediastinitis. And this inflammation can spread really quickly, becoming systemic, affecting the whole body, potentially leading to sepsis.
That sounds incredibly serious and, yeah, really fast-moving.
Yeah.
So someone comes in with that sudden awful chest pain after vomiting. How do clinicians figure out it's Boerhaave and not something else that looks similar? What else is on the list?
That's a huge challenge diagnostically. Boerhaave can really mimic other acute, serious chest pain causes. The differential diagnosis is crucial. You're thinking about acute myocardial infarction, a heart attack, pulmonary embolism, a clot in the lungs, aortic dissection, a tear in the aorta, all big, scary things with chest pain.
Yeah, those are all emergencies in their own right. Anything else that might present similarly?
You also have to consider a perforated peptic ulcer, a hole in the stomach, or duodenum leaking contents, and maybe spontaneous pneumomediastinum, sometimes called Hammond syndrome. That's air in the mediastinum, but crucially, without the full esophageal tear. So you really need to look closely at the history, the exact symptoms, the physical findings, and definitely the imaging.
Right, putting all the pieces together carefully.
Yeah.
You mentioned it's rare earlier. How rare are we talking?
It is quite rare, thankfully. It probably accounts for only about maybe 15% of all esophageal perforations. So while it's critical to know about, it's not something doctors encounter every day.
And who typically gets it? Is there a specific demographic?
It tends to affect middle-aged adults most often.
Yeah.
Sort of the 50 to 70-year-old range is typical. And there seems to be a slight male predominance, occurs a bit more often in men than women.
Okay, middle-aged, slightly more common in men. Got it. So what are the absolute classic signs and symptoms? What should make someone immediately think, could this be Boerhaave?
The absolute classic picture is that sudden onset of severe chest pain or maybe epigastric pain high up in the abdomen. Patients often describe it as feeling like something is tearing or ripping inside. And crucially, this pain almost always hits right after an episode of forceful retching or vomiting. That sequence vomit, then severe pain, is a major red flag.
That timing sounds key. What other symptoms might go along with that horrible pain?
Well, besides the pain, they might find it hard to swallow. There's dysphagia, or painful swallowing odonophagia. And then there's subcutaneous emphysema. That's air trapped under the skin. You can actually feel it. It crackles when you press on the skin, often around the neck or upper chest. We call that crepitus, like Rice Krispies under the skin. They might also be short of breath, have a really fast heart rate, tachycardia, and sometimes signs of shock or sepsis, low blood pressure, confusion.
That crepitus, the crackling skin, sound like a very specific clue. Anything else on physical examination?
Yes, listening to the chest is important. Besides potentially hearing signs of a pneumothorax or effusion, you might hear something called Hammond's sign. This is a crunching or clicking sound that's timed with the heartbeat. It's caused by the heart beating against air-filled tissues in the mediastinum.
A crunching sound with the heartbeat. Wow, okay, that's distinctive. Now, I've heard of Mackler's triad. What exactly is that and how useful is it?
Yes, Mackler's triad. It's a classic trio of findings that strongly points towards Boerhaave syndrome. It consists of 1, vomiting, 2, lower thoracic pain, and 3, subcutaneous emphysema. There's a helpful mnemonic. My tummy vibrates. Think mediastinal crunch or emphysema, thoracic pain, and vomiting. Now, not every single patient will have all 3, but if you see 2 of them, especially the vomiting followed by pain and maybe some crepitus, you should be highly suspicious.
My tummy vibrates. That's a great one for revision. Okay, so Mackler's triad puts it high on the list. But how do you actually confirm it? What investigations nail the diagnosis?
Yeah, you need imaging to confirm it definitively. Usually the first step is a chest x-ray. It might not show the tear itself, but it can show signs suggesting it. Think A-piece for the findings. A for apical pneumothorax, maybe a small collection of air at the top of the lung. P for pneumomediastinum, air in the mediastinum. E for effusion fluid around the lung, a pleural effusion. And S for surgical emphysema, that's subcutaneous air, sometimes visible on the x-ray in the neck tissues.
APES, another good one. APES for the x-ray. But that's often just the start, right? What's the main imaging test?
The gold standard, the best test, is a contrast-enhanced CT scan of the chest and abdomen. You give the patient contrast material to drink or intravenously, and the CT gives these detailed cross-sectional pictures. It can often directly show the tear in the esophagus, plus the extent of any air or fluid leakage into the mediastinum or pleural space. It gives a much clearer view.
Right. The CT gives the definitive picture. What about looking inside with a scope, like an OGD?
An OGD, or esophagogastroduodenoscopy, can be useful. Passing a camera down lets you see the lining directly. You might see the pear, assess its size, look for underlying problems like tumors or ulcers, but it needs to be done really carefully. You don't want the scope or the air insufflation to make the perforation worse. Sometimes it's done after initial stabilization or even during surgery.
Okay, so CT is primary. OGD can have a role, but needs caution. Once the diagnosis is confirmed, what happens next? How is it treated?
This is a true surgical emergency. Time is absolutely critical. The immediate steps are resuscitation, stabilizing the patient, fluids, oxygen monitoring, and then prompt surgical intervention. The goal of surgery is to repair the tear and clean out the contamination from the chest.
Surgery sounds essential. What else is crucial in the immediate management?
Absolutely vital are broad-spectrum antibiotics started immediately. You have to cover the bacteria leaked from the gut into the chest. And getting a surgical team involved very early, ideally specialists in esophageal surgery, is key for the best outcome.
Makes sense. What kind of surgical procedures are we talking about? What are the options?
It really depends on the situation. How big is the tear? Where is it? How long ago did it happen? How sick is the patient? If caught early and the tissue looks healthy, the preferred option is usually primary closure, just sewing the hole shut. But if there's a delay or lots of infection and damaged tissue, direct repair might not be possible or might fail. Then you might need esophageal diversion, basically bypassing the damaged area with feeding tubes like a gastrostomy or jejunostomy to let it heal. In the worst cases with extensive necrosis, part of the esophagus might need to be removed, an esophageal resection.
Those were all major operations. Really highlights how serious this is.
Yeah.
What's the outlook for patients then? What's the prognosis like?
It's guarded, honestly. The prognosis heavily depends on how fast a diagnosis is made and treatment starts, also the amount of contamination, and how successful the surgery is. Unfortunately, even with modern treatment, the mortality rate is still significant, often quoted in the range of 10 to 40%. It's higher if there are delays, if severe sepsis develops, or if the patient have lots of other health problems.
So that speed of diagnosis and treatment we talked about is absolutely paramount. And even if someone survives the initial event, what sort of complications can occur down the line?
Yeah, even after getting through the initial surgery and illness, complications can still arise. Things like persistent sepsis or SIRS, systemic inflammatory response syndrome. You can get abscesses forming in the mediastinum or collections of infected fluid empyema around the lungs, even lung abscesses. Longer term, patients might develop esophageal stricture scarring that narrows the esophagus, or fistula's abnormal connections between the esophagus and, say, the airway or pleural space. And problems like recurrent acid reflux, GORD, are also common.
So recovery can be long and complex.
Right.
Okay, to kind of wrap this up, what's the absolute key message for someone revising Boerhaave syndrome?
I think the main thing is, remember, it's rare, but it's lethal if missed. You have to think about it. Know the risk factors. Recognize that classic story forceful vomiting followed by severe tearing chest pain. And be aware of the key clinical signs, especially Mackler's triad, my tummy vibrates, mediastinal crunch emphysema, thoracic pain, vomiting, and those key imaging findings. Remember, APEs on the X-ray, and that CT is usually needed to confirm. Rapid diagnosis and rapid surgical referral save lives.
Brilliant summary. Those mnemonics are definitely keepers for revision. Okay, one final thought to leave people mulling over.
Maybe just consider, how do you maintain that high index of suspicion when the presentation isn't textbook? You know, the patient who maybe didn't vomit dramatically, or the pain isn't quite so severe initially. How do we catch those subtle cases early, too?
That's a really important challenge for clinicians. A great point. And for all of you listening and deep into your MSRA revision, don't forget to check out pastthemsra.com and freemsra.com. Loads of fantastic resources there. Thanks so much for taking this deep dive with us today on Boerhaave syndrome.